All right, so talk about toxicology tonight. There's all different types of toxicology. We'll hit a couple of them. I think one of them in here is kind of pretty funny, um, that talks about toxicology. But all right, so toxicology, the you'll deal a lot of that with through as you go through here is overdosing, um, and somehow to recognize, even though if you accidentally overdose on, let's just say Tylenol, that's considered a toxicologist that has to come out and work with you in the hospital, and then they turn around and have to be seen, and then you go through these mental health environment, evaluations. And you're like, bro, it was just accidental on Tylenol, my bad. So toxicology is, I want you to recognize the management of carbon monoxide poisoning. We know that's an odorless, colorless gas that is seen, can't be seen, but it is deadly, very deadly. And how and when to contact poison control. I can tell you, for example, prime example, don't ever reach out from poison control from your phone if you're calling about a patient. Always call from the patient's phone because they call back religiously. They call back all the time, every 3 hours until it's like a 12-hour mark. So that's part of it. So FYI, if you call from your phone, it's going to be a while and they're going to talk about it and they're going to want to call and check on the patient and all this stuff for hours. So I always like to say use the patient's phone. So here, so there's all different types of poisons. There's all different entry routes. As you can see, the inhaled, ingested, injection, absorbed, and alcohol intoxication. So, and also withdrawals is a big one. That is something that's going to have to be seen too. Is it is a form of toxicology because of it's a withdrawal from a consistent use of alcohol. Um, I've seen patients go through withdrawals. I've treated them for years, and it's very hard. It's just as much when they're starting out to come off of alcohol. So let's see here. Every day we come in contact with things that are potentially poisonous, and just think about in your environment uh, of what you deal with. Maybe just taking your regular everyday medications versus um, right now as we're dealing with the storms and all that, we're running these generators. Well, if the wind goes to if a different direction, you may get a carbon monoxide poisoning just because of its location and all that. So that is also something that needs to be thought about and time and placing. I saw that this company had come in and replaced a Generac generator in this guy's house, but their placement was very bad because where they placed it, the placement was right by the dryer duct that came out of the dryer from the house. So the exhaust was going straight back into the house. It was just bad placement. They ended up getting it fixed and all that. But so deaths caused by poisons are fairly rare. They are recognized unless it's something that is it's a late recognition, and it does happen to be by poisoning later on. Rates of death as a result of poisoning in children have decreased steadily since the 1960s. Um, and the biggest reason is the child resistant caps. When you go to the pharmacy now that they have these child-proof caps, and some of them really suck. Try to get them off. You feel like an idiot, and you're trying to work on these things, and you're like, oh my god, what is wrong with me? I don't know how to take this cap off. And then they're challenging. Maybe that's just me. I'll say that. Deaths caused by chronic poison in adults have also been on the rise. When I was going through one of my classes, we talked about poisonings and all that. And then one of the things that they specifically spoke about is the overdosing of prescription narcotics. Alabama right now, who knows why? Maybe it's because they're all. No, I'm just kidding. But Alabama gives out more prescription narcotics than any other state in the country. So that's just like why. I mean, there's a big study out on why that's being done and like how to prevent that. But it's pretty weird how that is Alabama out of all 50 states that has that. So we're talking about how to identify this. So you can read there. We know toxicology study of toxics and poisons of substance. So that's cool. We know that. So our question is what do we need to know that for? Well, poisons get into the body. Well, if we know how they got in there, maybe we can help clarify that. So if we say, okay, so they did an inhalation, well, if the proper equipment's there and the proper people are there and they go in and remove them, removal to clean air may be a big part. And then adding just supplemental oxygen may help fix the patient's condition. Now, if you have like a chlorine gas or something like that, that's completely going to another realm. But just let's just say carbon monoxide, moving them to a fresh air. They have that bright red cherry skin. Their mouths are really dry. That's some signs of carbon monoxide. Toxins can have an acute or chronic effect. So if it's something that is just one time, that's an acute cause. If it's something that's a continuous poison, that's going to be more of a chronic. Prime example, substance abuse is the misuse of any substance to produce a desired effect. Any street drug, any regular narcotic. If I want to take it because I'm in chronic pain, then that's why. That is something that I'm trying to reach out consistently to get that pain to go away. A common complication of substance abuse is overdose when the patient does take too much, but it's because I'm always, so I like to say, so crack is probably one of the most drugs that I'm ever scared of. Cocaine, marijuana, heroin, and all that really doesn't bother me if I was to go try it. But crack cocaine or crack period is it gets you because you always chase that initial high. No matter what, you can't get it back. Like you can't ever get that initial high. So, and at the same time is people that take these pain medications, you may start off with, 5 milligrams, and then the next one you take 5 milligrams for so while as your levels have gotten higher, and now you're increased that to 10 milligrams. Well, you're continuously to do that. Well, then one day that you think that you have a 10 milligram pill, you're going to turn around and that'll be a 15 or a 20 milligram pill. And then you're like, oh God, that may be why they overdose. It's because they're chasing a new high and their toxicity levels have gotten higher. What is our primary responsibility to these patients? What are we looking for? How do we know what to do when we don't recognize? So my question to y'all is, what is our primary responsibility to a potential overdose? And then what are we looking for to give us that it isn't signs of overdose? Anybody? Man, y'all so quiet tonight. What's up with this? So I want to know if it is on purpose. Is it accidental? Did they do this because somebody tried to poison them? Um, what has led me to be there? What does my surroundings look like? I want to be very observant to, does it look like this is a potential domestic violence? And I'm not just saying men on women, but women on men too. Is what do we see? Um, is the aggressor trying to talk to him and be like, well, they kept saying they had a headache, so I just gave her the medicine, and she just, I need her to talk, or I need that patient to talk, and that's where you may want to try to separate them so you can get that right point of view. All right, so here's your identifying the patient's poisons. So opioids, sympathometics, sedatives, anticoagulants, and then some of your orgophosphates, all in your nerve gases, they all show different signs and symptoms. When they have all these different signs and symptoms, that right there will tell you potentially of what's been taken. So if you'll look over here, so your opioids or your opiates, heroin, fentanyl, oxycodone, you're all going to have those pinpoint pupils. They're going to be hypotensive, and they'll have hyperventilation or respiratory arrest. And that's because it's it's a downer. I want to slow down. I just need things to move by and me just chill. I don't want to feel my surroundings. So that's some of the things that you can get from opioids. And that's why you need to know the difference, because certain drugs, when we all think, oh, I'm going to use Narcan, well, certain drugs do not react to Narcan. Somebody tell me what class of medication does not react to Narcan.
Are you talking about controlled substance wise? Like 1 through 5?
I'm just talking about in general, because it. Well, it's only going to work on an opioid, right?
Right.
Um, certain certain prescribed narcotics, it's not going to respond. So if everybody's like overuses the Narcan on Fred, well, after a while, Fred's going to build up a toxicity level to Narcan because he makes you think he's using opioids, but he's really using prescription drugs. So that's where I was meaning as what classification, and I guess knowing the background that you have, I see where you're asking if you wanted to know what schedule, but no, I really just want to know like what does it work on opioids versus prescriptions, and I kind of gave you your answer, but Caesar was on the point. He's listening to us. We're halfway there. So here, identify the patient and the poison. Now, we may not be able to. They may meet us en route. They may say, "Hey, we're going to meet you at Wendy's," and they're going to pull up to Wendy's, and you're going to be waiting on them, or vice versa. So we may not see what they got poisoned to, but start building a very good basis. Ask the family members, ask the patient who's with them. If the patient's unresponsive, you need to ask questions that the most amount of questions that you can build before you transport them. Um, Again, there's all those questions. What we want to know is, and the reason why the weight is important, and that's because we need to know how much medication that we can give them once we get to the facility or even en route to help reverse that. If that's something that we can do, certain agencies carry different reversal drugs. They're weight based. So we just need to know those things. When did you take it and when did you become exposed? Well, that's important because if they took it 10 minutes ago, maybe charcoal will work for it versus pumping their stomach. Well, we can't pump their stomach, but they can pump it once they get down. But if we load them with charcoal, then that should be fine. So the timing of that is very important too. So again, building a good sample history will allow you to get that information that you need. Determine the nature of the poison. Look around the immediate area for clues. Look for syringes, pills. They say chemicals, but I'm not real sure how you're going to be looking for that to understand, because you may not just know what chemicals are around there. See if there's any types of food or drink items. Maybe they drink it. Even an overturned or damaged plant that they may have, whom knows and why, but certain house plants are very fatal, even though they're very pretty, specifically to animals too. So be cautious of that. Containers on the scene that may have some critical information, look for the concentration of the drug, what ingredients were in there. And that's what's great about us. Everybody, no matter where you're at, you have a camera phone. So taking pictures of these versus bringing them to the facility is awesome. Like there's a poison control doctor that works at our trauma center, and he is a snake fanatic. So if you have a snake bite, he's like, "Oh, bring it to the facility." Not no, but hell no, I'm not putting a snake in my ambulance and bringing it to you and let you look at it. No, sir. You can look at it through the camera and it's going to be from a distance. I'm not doing it. So I want to know potentially what the manufacturer is. So if they're exposed to a chemical, a quick snap picture of what the chemical container is may help you diagnose, or may help them work on a compound. And it may be a rubbing compound that is required versus a compound that they can give. Sorry, I'm trying to thought I was looking for something else. So if it's a compound, something that they can put over the area, or versus a medication is basically what I'm trying to say. So they may compound it, and the picture of the container may help out drastically. And then what is the prescribed dose versus what they had? So if you go somewhere to take care of somebody and they have a bunch of pills, and me just being me, I kind of point the pills out and I'm like, well, there's like 10 here. And if there's only 10 and they got it like 5 days ago and it's a bottle of 30, well, I mean, that's obvious. So things like that may help you build out, be like, well, looks like they took a lot of this, because why? Now you can ask those questions. Let's see here. If the patient vomits, examine. Nope, not. I'm sorry, I'm not doing it. Y'all can read that your own. I don't do vomit. I don't sit there and read and try to figure out what is in their vomit. I don't want to know. I don't really care. That's like them trying to say bag it and bring it to the facility. Nope. Not gonna do it. That patient's on their own. I don't do vomit. And I'm asking you, if you happen to see anything unusual too in the vomit, but Chris Wiley's not doing it. I mean, it's probably a test question, but no, I'm not shifting through the vomit. Hammer, I'm the same way with boogers. I don't do it. No, you get sick in my truck and you don't tell me and I can fix it. That's on you. Yeah, and my wife's over at 10. I don't do teeth either. Like when my kids' teeth are like pulling, like, I don't do teeth. That's on y'all. All right, so how do poisons enter the body? We roughly went over this in the beginning, but so I'm gonna ask y'all a couple of questions at the same time. So if y'all want to unmute your mics, that's fine. But I want to know what type of toxin that can be inhaled.
Nerve gas.
All right, nerve gas. All right, what about absorption? What can be absorbed? And that means surface, this, like if I reached over and touched it, what can affect me?
Fentanyl.
All right, I was hoping that was going to be, because that's a big topic right now. There's been some studies out saying that fentanyl can't be absorbed in the skin, then it can be. I just don't want to mess with it because it's dangerous. All right, so what can we ingest that also is a toxic?
Different household cleaners.
All right, perfect. So if you accidentally, let's say, I don't know, you get it on your hand and you're trying to get something out of your mouth, you can ingest that. Let's say nitro and paint. So absorption is nitro, and paint you can ingest. All right, what about injection? What poison can be injected?
Use needles.
Correct. That's a bad one. You can get a needle stick. Now I got one for you that is I've worked this, and I actually ended up having to place a tourniquet on this guy. It's a busted hydraulic line, and hydraulics are under heavy pressure, and this about 2 pints were injected into this guy's leg before he was able to move, because it was under such high pressure. And we were able to sit there as we were transporting this guy, watching it move up his leg, and it was going to kill him. And I actually put a tourniquet on his leg to stop it. And I put one direction, the other one the other direction. It doesn't really matter as long as they're both on there. But I didn't do high and tight because I was trying to, control the leg, but that is also an injection, and it's a hazard. The dude actually lost his leg from the knee down, but he could have died. So I figured that was we'll give and take a little bit. So here's different types. We already talked about that, and look, somebody talked about needles. It's right there. I kind of jokingly laugh because his tourniquet right here is not really good for him to inject that. So bad picture. Rubber cement, y'all know, as we all kids, we've done that. Y'all can say no. Of course, we know you painted on your fingers too, and you pulled it off. Tamara says, could epi be toxin if not needed and accidental stick happens? No. And the reason why is because epi is it's it's already produced in your body. It's like atropine. Well, epi and atropine are going to make your heart race. Now, granted, it may make you nauseous, it may make you blurred vision, it could possibly do a few things like that because of the overload. But still, if you're getting stuck by it and it's not yours and it's already been stuck by a patient, that's potentially an injectable hazard right there. So that's something that's so yes and no, because I look at it in both ways. Sounds like the ultimate pre-workout. Just make your own little cocktail. All right, so some inhaled. So the best thing we can do for them is literally the top two things. And almost all I'm going to read, we can go about it later, is fresh air, move them to fresh air without causing harm to yourself. If you notice the patient is in a very bad area and you can see a potential haze or a cloud, or you do not go in there because oh, I can hold my breath that long. No, not when you're pulling a 220-pound grown ass man that ain't doing nothing for you to help you move. You can't do it. All right. So that being said, is let them wait until the first responders get there and they have that particular equipment. So then they can go in there and get them. If you just and then put the patient on supplemental oxygen, because what we're trying to do is flush that toxin out of their lungs all the way down to the bronchiole. We just want to flush it with high flow O2. Simple. All right. So now on inhaled, some patients may become a decon. That is true. It depends on what type it is. If it's like a moist, like a mist vapor, it could need to be deconned. But any type of chemical exposure, there needs to be some form of decon, because as soon as you put them in the back of your ambulance and you shut the doors, now you're automatically exposed. So you have to be cautious about that. Some patients use inhaled poisons to commit suicide. Yes, they do that. Stick the water hose in the car and then run around, or either crank the car in the garage and then they turn around and what are you doing? Oh, thank you. So then they turn around and put it in there. So they try to commit suicide that way. So those are two different big types that you'll see on inhaled. So on absorb. So this is just, it's a skin contact. We're talking about a mucous membrane. It could be a splash to the eye. It could be in an inhale of any form or fashion. Chemical burns, rashes, or lesions. Systemic effects. It is important to distinguish between a contact burns and a contact absorption. So the biggest thing that you can do there is the contact absorption is going to be obviously it's going to be red. Then you're going to start to see the streaks throughout the body, or through the arm or the leg or the chest or the face, because you can see where that toxin's starting to run. Now, a contact burn, no matter what, either of these need to be brushed off, not washed off, because you don't know if this chemical it reacts to water. So that's something that I say and I'm not knocking anybody's experience, but we as first responders may not have the hazmat training to distinguish between that. So if you're a hazmat tech responder with your fire department, but then you go work for a private ambulance service as a EMT, advanced, or a paramedic, you're no longer in that role to be a hazmat technician. You're just an EMT and paramedic. And I'm not trying to say that's just, but understanding your role is the most important part, and it's most beneficial to that patient. That's something we just have to be. It sucks because you have all this knowledge and you're just like, well, I don't. I mean, it will help your patient, but you have to remember your role. So signs and symptoms of any absorption is right there. The biggest one you're going to see is redness to the skin and any irritations. Not all the times you'll have itching. You will have sometimes a burns. And when they talk about a history of exposure, maybe this particular person works in a plant and that chemical is around and they're supposed to have a respirator on at all times. Maybe they don't, they cheat the system and they're like, oh, I've been here 40 years. And they're, well, that's what happened to Fred. Freddie was there one last time and his ass didn't put that respirator on and now he's dead. Well, that's Fred's problem, you know, but that's a chronic exposure. So that may be where you have those issues there. So emergency treatment, again, the most important one is stop. Avoid contaminating yourself or others. Well, currently your other is your ambulance. Hey, hang on 1 second, y'all, real quick. All right, so sorry about that. All right, so you remove all contaminants from clothing. And again, you may have to remove all of the clothing in general. I only need that one. I don't need that. That's no, that's enough. All right, so if you have to, I say strip and flip, and that's the thing is it's not, you just need to remove their contaminants. But remember, you still have to keep the decency of this particular person. So being careful of not saying, oh, let's cut her clothes off. Whoa, bro, you're in the Walmart parking lot. You can't just do that. You have to be cautious. I mean, you can, but somebody's not gonna like that. Like I say, it's easier for me to put, people only start complaining when I take more clothes off. So I like winter. I like winter because I can keep clothes on and nobody complains. So then you flush the skin with water. Well, I'm sorry, flush and wash the skin after you know what that chemical is reactive to. You may just have to strip this person and wait for better guidance before you start washing them. Because if you expose them to water and this chemical reacts to it, it's actually probably going to be worse on that patient than just leaving them where they are, because now you've created harm towards a patient that you take care of, and that's not always the best thing. So here's it very important. So if it's a dry powder, do your best to brush it off. You can use some pieces of paper. You can flush the skin or brush the skin. If it's in an area where you can flush it and you know that somebody's told you that the safety data sheet, which is called a SDS, or it's been advised that you can use the water, you want to flush it for 15 to 20 minutes. Now, again, it doesn't need to be cold water and it doesn't need to be boiling ass hot water, just room temperature water. Depending also if it's been, here's a picture right here, if it's been in contact with the eyes. So here's a trick. If you'll notice right here, what they're doing is they're using a nasal cannula, reversed, and they are injecting a 60 cc syringe with saline water, and they're flushing the eyes this way. We do this a lot offshore. The number one injury we get offshore is something in my eye. Well, we got to fix it. That's the biggest injury that there is. So what we tried to do, and the key word is try, is to flush their eyes. If we can flush it out of their eyes, then they can return to work. We also use this stuff offshore that we can dye their eyes to see exactly where it's at. It's pretty cool. It's reactive to black light, but it helps. So I'll just say use the trick of the nasal cannula. It's very, very helpful when you're trying to flush somebody's eyes versus trying to flood their face with a bottle of water. You're like, I can't breathe because it's getting in my face. So just remember the nasal cannula. It's a pretty cool trick. I can say I've actually not been to many chemical plants for an exposure. I've had more happen at home. And I think that's wise because the industrial setting, the oil field, the fire service, they're preached about safety, 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 safety. So they take more precautions. They're not as in much of a hurry or just things like that. So when you go to be very careful on how you handle these patients. Um, yes, Rebecca, we use fluorescein. It's a really, really cool stuff. Um, so anytime you may have this patient in your ambulance and you're transporting and you realize it's a worse chemical than what was initially told, make sure you relay that into the emergency department that you're going to so you don't take contaminated patients into their ER. So if that's something that you can do and just let that patient uh, be decontaminated before they make entry and with medical assistance there, they're going to be more happy for you. The ED is going to love you. So on ingested poisons, you have about 80% of the poisons are done by mouth. And just think that's how we do a lot of the things. I would be more inclined to say it would be by inhaled because we breathe when we're asleep. We breathe and not thinking about it. And they're going more towards about the liquid, the household cleaners, the plants and the drugs, and then the contaminated food. And I don't know how far they're going on the contaminated food, if it's more like salmonella or stuff like that. But the plants and drugs, you'll see in a second where they go down that road. Kind of funny. So as you have these ingested poisons, they are usually accidental. They're never like, oh well, I tried. Well, hang on, let me say that. 90% of the time they are accidental, and then you have your couples on the side that do try to do it and harm themselves by suicide. But you do have signs and symptoms that are. I'm sorry. Oh, so you have type of the poison, age of the patient. So how old are they? What are they? What's their general idea? Um, Time that the patient has passed since the ingestion. I need to know that because that's important on how we treat them. It's the same thing of like a stroke and stuff like that. We just need to know times. Signs and symptoms include burns around the mouth, gastrointestinal pain, vomiting, cardiac dysrhythmias, and seizures. The biggest thing that you need to be careful about here is when they start vomiting, they're going to have a esophagus burns on the way in, and then they're going to have esophagus burns on the way out. So you can imagine how raw and irritated their esophagus is going to be because of this chemical. They thought that they were just going to try to harm themselves and kill themselves, but it didn't go that well. Now that they're in a worse state, you think about that in advance, that you're like, oh, well, they drink Drano. Oh God, now that's going to be a esophagus burns. Could be respiratory, depends if they got it down their lungs, or worst case scenario, they start having season, and then when they seize, they will probably stop breathing and go into cardiac arrest due to the dysrhythmias that's going to be caused. So how do we treat this? What are some of the things that we're going to do to treat these? Well, that's something we need to know. So, if a patient has altered mental status, what you want to do is just mainly protect their ABCs. So protect the patient. If they do vomit, you don't want them to aspirate. So putting them on their side, let them vomit vigorously. You can suction at the same time. Consider whether there is an unabsorbed poison there may remain in the gastrointestinal tract, and it potentially can be absorbed that way. Now, granted, we're not going to try to flush the gastro tract down, but just knowing if they need to spit, let them spit in a cup, let them spit in a suction container, something to that, or even put the suction catheter up to their mouth and just let them spit that way. So we also use charcoal. You hear Actidose, activated charcoal. This is, I've told y'all before, this is it will get everywhere. But if you give it, you have to give it all. You can't just get 3 of the 8 ounces. You got to give it all. It's just the way that it works. Sorry, y'all, I was trying to chew and not make it obvious, but I can't make it. All right, so injected and poisons. Let's see, exposure by injected includes intravenous drugs and use of envenomation by insect. So knowing your areas, I had my very first ever scorpion contact at a elementary school. Kid went to Texas, went to visit a family, school came back, and he grabbed something out of his bag and a scorpion fell on the desk and they all freaked out. Kid said he got bit, but never really happened. But it's something that we had to learn how to deal because we've never dealt with that in Central Mississippi, of that being a complaint or an issue. Now, granted, you do have your wasp and bee stings, your hornets, things to that matter, but those normally can be fixed by, by your epi, your Benadryl, as you transporting them to the hospital. But knowing your areas, if you say, okay, now I'm going to go work in West Texas, you may have some more of like the rattlesnakes, the venomous. Yeah, you have them here in central part of the US anyway, but you may have those incidents to where you have more exposure to them. Knowing what facility has that anti-venom or is like Arizona has a very big progressive snake bite protocols and procedures and all that. Some agencies actually carry the antivenom because it's so common out there and the EMS actually gives those. But that's because that happens out there. Let's see, I probably talked too much about that. So what we want to do here is you want to just watch for the signs and symptoms that they present. Again, protect the airway because the airway is it's our golden track. We know you got to have air in and out. So if you clog that airway with something, the respiratory drive is going to decrease and it's going to be blocked. So our ultimate goal is to keep them having that respiratory drive so they don't go into respiratory failure. Anytime you start to get here, remove, I like to do this at the home so you don't accidentally forget something, but you remove all jewelry, even to earrings, to nowadays you got to look for the tongue rings, the belly rings. Be cautious also of other body jewelry. Some may be hidden, some may not be. You have to be very cautious on how you look for that, but remove it. Be very careful, make sure those stay at the residence, but you want to remove that as fast as you can because if there is swelling, you'll end up having to cut it off or it'll restrict the blood flow in that particular area. So your size up, I need to know what am I seeing if I'm potentially going for a chemical exposure? Is there an odor? Is there not an odor? If the patient's been bitten by bees, where is he located? Did he run away or did he, get bit by several bees and collapse right there? Well, where is the beehive? Where's the hornet's nest? Is there a danger that can still affect me? Syringes, that is one of the biggest things that we have to be careful of, not only because, well, that and assault. Those are 2 biggest issues because not a lot of people, well, in that state of mind, remember that they have an open syringe in their pocket. Well, I'm not searching your pockets anymore because I don't play cops, but as you're taking care of this patient and they move that and you got your hand in that particular area, it could poke you through their skin or through their pants and all that. So you have to be careful. Keep a constant eye on your surroundings and keep an open mind when you question your patient or the bystanders, because you don't want to be mistaken and you don't want to be like, oh, well, this is what it is. No, just listen to what's being said. Don't form any opinions. Make suggestions, because I mean, you could be completely wrong and making a bad decision or a bad call, and it's going to look bad initially after a while after you talk about it, because you're like, oh, well, that's not at all what I thought of, and you just look like a bad guy or gal because you made that thing. So your primary assessment. What is my general impression? How are their level of consciousness? Are they maintaining their own airway? Are they awake, alert, and oriented to person, place, and things? Is there any potential life threats that they show that would affect me and my crew? What does that say? Do not assume on conscious, alert patient or stable condition. Because at this point, that patient can fail and they can go unconscious, and then they can crash very fast. So you have to be cautious on that. Just because that there's an overdose, you really probably should treat this as a non-stable patient until proven otherwise. So your rapid assessment and your care needs to take place in that first 5 minutes, and then you do a reassessment, because you need to stay ahead of that game. If you treat them as non-critical, and you just because they're awake, alert, and oriented, you may get behind the 8 ball and have to play catch up. We talked about their airway and breathing. We made sure this is the most important thing that we can do right here. Have suction available, because it could be to where now this patient's now they're having trouble swallowing. Well, it's got to go somewhere, and you need to suction it out. If they start vomiting, you can assist with suctioning it depending on where they are. Circulation, just assess the skin temperature and condition. Do they have a pulse? Yes. Is it, what's their pulse rate? Now you're building that baseline. It's pretty cool to have your baseline and see them digress, and then your treatments make them better, and then you can actually see that as you do your documentation. Transport decisions. I want to know very quickly what their transport decisions are. Can I take them to the hospital slow and methodic, or do I need to go lights and sirens? If it is a contaminant, do they need to be decontaminated by the hazmat team before we leave? How long is it going to take for the fire department to get a hazmat team there or set up for decon in their area? That may not be something that the fire department practices on the regular, so they may not know how to do that. So think about that as you get ready to transport also. History taken up with an exposure is just like everybody else. It's just as important, and it's not something that we don't want to do. We want to know pretty quick with the history, because then most of the time you don't want to stick around. You want to just you want to have some urgency to load this patient and go, but you're not treating it like, oh well, they just slipped, tripped, and broke their ankle. I mean, this is life threatening at the same time, but you just need to be observant to make sure you get your good information so you can pass it on to the hospital once you get there. There's your sample again. I'm hoping to this point that that's self-explanatory, that you know that these are just mnemonics that you can use to build your history taking. Sorry, I'm chewing again, y'all. Those are good questions right there. My wife's mad. I ate her Twix a while ago, and she was looking for a Twix, so sorry. Again, those are some good questions that will help you. So maybe something as you start to build your assessment skills, that these are some of the questions that you can add into there. Focus on the body area involved with the poisons or route of exposure. Uh, yeah, so if it's an ingestion, I'm not going to sit there and say you need to assess the mouth every couple of minutes, because that's not really true. You need to continue doing an assessment of the entire body. Will help you get your assessment down pat and help you understand what and how to treat this patient. So that's important too when you identify the particular area, but your baseline vitals is just as important as everything else as you're assessing this patient. So using common sense and treating the patient as they present to you is going to help you just as much. Your reassessment. So what I want you again, when you reassess, it shows every 5 or 15 minutes, depends if they're stable or non-stable. You just need to continue. It's a I hate to say round robin, because it's not, if y'all know baseball and round robins, it's not that pattern, but you need to continuously check this. You need to build your patient assessment around checking them every 5 to 15 minutes. I know I have an internal clock to where when I hear the blood pressure go off, I need to start checking them again, because it takes the blood pressure about a minute, minute and a half for the machine to go through and cycle through and get it. Well, I can reassess and ask the questions of that affected area by the time the vitals get through. Now, as I've treated a trauma patient, it may be a little different, because it's always go, 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 go until you get to the facility, because it's a life-threatening issue. So I don't ever really pay attention to the blood pressure machine or the monitor as I'm working a trauma call. I just have my own pattern. So that's something I can't really teach you guys, but you do in your assessments, you're hands-on at your home right now, asking the questions that you see, and knowing that you're on a clock by your vitals will help you improve things. I'll make sure to point that out to some of our instructors at the boot camps, that you need to focus on working on your assessment and building your patterns and the way that you do things. Your treatments, so managing airborne exposures with oxygen, because you put that mask on them, it's not a filtered mask when it comes out, but it keeps the majority of it from coming back up, because it is a pressurized oxygen delivery system. If you can remove the contact exposure with water, please do so. If not, then you take it for what it is and you rock and roll with it and you make things happen. So that being the case, be cautious on how you do it, because again, the contamination is an issue that you don't want to have to be treated because you didn't decontaminate your patient appropriately, or you may become a patient because you weren't advised of what the contaminant was. So knowing those will help you out also. Communication and documentation. Oh boy, get ready, because writing your PCRs, see, we've talked back and forth a lot on teaching you how to write reports, letting you understand how to write reports, but at the same time as agencies require so much different information that we really haven't built a so chapter on doing documentation. I'm going to cover it with you guys so you know how to write one and what goes in what boxes. But the information that goes in the correct text is up to you. I can't tell you how to write a report or what to put and what not to put in there. But overall, if you did something, it needs to be put in the report. If you see something, put it in the report. If you didn't do anything, if it's not written in your report, you didn't do anything, if that makes sense. So if you did it, you have to document it, period. And just seeing things, even at their home, I document what my scene looks like. That's how descriptive I get. Going to court is not the funnest thing in the world. So be cautious about what you do and don't put in your report, because if you don't put enough, it will come back to haunt you. So be very cautious there. Emergency medical care. Again, everything is, make sure the scene is safe. Remove tablets or fragments from the patient's mouth. Be cautious on sticking your digits in their mouth. Be cautious of that. Wash or brush the poison from the patient's skin. We just talked about that too. You need to know before you apply water on how to remove it. Assessing the ABCs, exposure, then your ABCs are, be cautious in that order. It could be circulation, airway breathing, because if they're bleeding, you need to fix that before you go on to the ABCs. Provide oxygen and perform assisted ventilations if necessary. If the patient is not breathing adequately enough, supply them with a bag valve mask where you're assisting them every time you squeeze the bag to help them breathe better. It's okay, that's fine. Some EMS systems allow EMTs to give activated charcoal by mouth. Again, you need to know what your local protocol says. If your local protocols allow you to do that, then do it. If you've never done it, ask a lot of questions before you do it. But it is a simple process. It's not something that you should be scared of. It's like giving Narcan for the first time. I always like to find the new people that's never done it and allow them to do it, because they're doing it in a training setting. Yeah. So it's, I want to say in a training setting, but it allows them to do it with somebody, other care provider going to be there. Contraindicated patients who, all right, so we don't want to use activated charcoal on anybody that has ingested a alkali poison, cyanide, ethanol, iron, lithium, methanol, mineral acids, or organic solvents. At the same time are you going to know those right off the bat when they just say they've ingested a poison? Well, I need to know if it's a cyanide. Well, I mean, cyanide is rare, but it also does grow in the wild. I don't know, you know what I'm saying? So it's not like I just didn't know, and I knew that they said that he swallowed something. So I did what my training taught me, is to apply, what my protocols say is we put an activated charcoal. Now, your methanol, I mean, that's a gas. So if they drink gasoline, it ain't gonna fix it. I mean, Darwin's theory has to fix the stupid, but it is what it is. So if your local protocols permit the 50 grams of activated charcoal, that is 1 gram of activated charcoal per kilogram of body weight. If you don't know how to get your kilograms, that takes 100-pound patient and you divide it by 2.2. Really don't. From my simple math, if somebody wants to give me the direct number, I always say in my head, take half. So if they're 300 pounds, I'm gonna have a 150 kilo patient, because it's quick and down and dirty math. So I'm gonna give them 1 gram. So I'll give them 150 grams of activated charcoal. That's a lot, but that's what it requires. So knowing how to get your kilograms is important. And the reason why, like I said, it is saying down, divide your weight by 2.2. But if it's something quick and you don't need to break out your Apple Watch or your phone to get the exact, just make sure you take half of what it shows. We're gonna finish these 6 and we'll take a quick break. Before you give a patient charcoal, obtain approval from med control. That's if you don't have protocols for that, you can call and request orders for that. But as you're doing it, grab that bottle out that cabinet and shake it, because it's just like anything else. It will settle and pack itself in the bottom. So it's very hard. And when you need to go to use it, if you didn't shake it up, it's like just a quick liquid. Record the time administration of charcoal because that's important. Because if they have to give another dose or they have to pump the stomach, they need to know a projected time, so they can either give more or like, okay, well, we can go ahead and pump the stomach now, but we may have this. Or so times are very, very important. And you can guesstimate the time going off of some of your vitals. Like if I gave it right after the blood pressure was done, and I can look on my strip and it says I gave it at 1900. Well, okay, so at 7 o'clock, 7:01, I gave the charcoal. It's just something like that will help you. I gave it at or around 17:01, 19:01. Sorry. So side effects for the charcoal is constipation because it's like charcoal. I mean, it's just like charcoal from your grill. It will stop you up. Obviously, you're gonna have black tardy stools. That's not your problem. I'm not trying to, tell you before it is. I'm just trying to save your life. You will see some vomit after this because that you got to rid the toxin either up or down. So once they get to the hospital and they may decide what poison it is, that's when they may try to put a tube down and suck it out your stomach, or they may try to induce vomiting. It just depends on the facility. But if they do vomit, be prepared for copious amounts of vomit and it to be solid black. And if it gets on something, I'm not saying it's like a sticky goop of everything, but it's thick. It stays there. It's not easily removable. And I say, well, let's just do these two and we'll take a break after these two. Over time, a person who routinely misuses a substance, we talked about that. So they build up that toxicity. Once they do, they're going to try to chase that again. So again, if Fred started at 5 and he needs to go higher, his tolerance is no longer meeting a 5. He's laughing at it because he's taken so many 5 milligram pills. He can take one every minute and it's not going to do anything to him. So he's going to up it to a 10, and that's where your initial overdose may come from because he's not used to that. It happens because their tolerance is so low. That it's going to happen on a lot of people that do that. Any substance can be abused. We have a state mental facility that's close to our house. It's probably, I don't know, 8-9 minutes away from us. They actually have people there that are admitted to the facility. They're actually addicted to drinking water. Like they get drunk off of water. They drink so much and intoxicates them. It has some particular name. I don't remember what the name is, but it's a hydro something. You can poison yourself on the water, so you have to be careful. So any substance out there can be a toxin or an addictant. And the importance of safety awareness and standard precautions is caring for a victim of drug users cannot be overemphasized. Don't ever just like think that they're not going to hurt you because Fred hasn't, Fred knows who I am. Well, Fred still kick your butt and he don't really care. Expect the unexpected and remember the drug user it's not the drug user, not the drug, can pose the greatest threat. So always keep your eye on them. Make sure your 6 is taken care of. Have somebody watching your back. If you're in the ambulance and you're transporting your patient, make sure your partner always has an eye on you as they're transporting. They need to be careful that they can watch you as you're going up and down the road, because if they particularly get agitated or they try to come up off the stretcher, you don't have a way to see them if you're not paying attention. So just make sure to be cautious and careful as you go through here, because that patient is going to get you. So I'll tell you what, let's take 10 minutes. We're at a good little point, and we'll come right back and get going in 10 minutes. Any questions where we're at right now? All right, good deal. So I will see y'all at 10 after 8. See y'all in just a few minutes. All right, folks, I'm back. So does anybody to this point have any questions or, concerns or anything y'all wanna, that we've talked about, wanna, pick up anything? I love it. Thumbs up, bro. Rock on. All right, we're gonna keep right along and keep trucking. Maybe. All right, so let's talk about alcohol. So I don't know everybody's background, but at some point in time, I'm gonna say at least 90% of this class has had alcohol. That's a pretty good assumption. Some of you, probably 75% of that, has had alone too much alcohol in their system. It's created, toxicity. You may have had some alcohol poisoning. At the worst case, I'd say that's probably maybe a 1% to 2% chance that there's been maybe potential battle with alcoholism. And then you have I'd say your 10% chance that's probably never had it, never been exposed to it, and they just choose not to, maybe from the past or just moving on. And that's fine. I think that's great. I never have faulted anybody for never doing alcohol, tobacco, or any recreational drugs. I think that's great. They all have their place and everybody has their own decision. And that's why I support everybody's decision, period, is to do what makes you happy. That's the ultimate goal. So with alcohol, we know that it can mimic other issues also. You can also, bourbon is the, I'm a bourbon guy myself. So, but so alcohol can mimic a diabetic issue, or if they're a diabetic or they're hypo, they can also give off the symptoms of being an alcoholism, because they give off that sweet smell to their breath that makes it smell like alcohol. The alkatosis. I didn't say that right. It's a sweet moisture of the mixture of air. So you have to be careful and don't just assume, oh, well, they're drunk. Well, no, maybe you just need to check their sugar, and maybe it's because their sugar's low, and that's where we are. We can fix that, and alcohol, we can help with that, but we can't fix it as fast as we can do a sugar problem. So, and there you go, Tamara. So you may have had that. So you got to figure out which one it is, and that's why I tell y'all, use your tools that you have to your ability. So alcohol can damage the liver. We know that. We talk about binge drinking. You can have your alcohol. It's a matter of fact, a very good friend of mine that's an educator now. He's battled alcoholism for the last 10 years, and he was a night drinker. He started drinking due to the death of his mother. He tried to do things, and he hid that for a long time. And he seeks treatment. His wife talked him into doing it, and he's a wonderful educator now. He's been a good educator. Nobody knew it. So it's you can do that. So there's different parts of it. So binge drinking is more of a chronic use. It's not something you're like, oh, I'm drinking a liter of tequila tonight. Well, you're probably gonna die. First off, I mean, you can try it for sure. You a grown man or woman, but just know it may have its potential issues there. So be cautious of your alcoholics, because as you can see, that's why I put it, it's a powerful central nervous system depressant. Sorry, my wife's cooking dinner and you probably hear the fries in the background. So it's supposed to decrease, it's like a sedative, let me say that. So it's a sedative and a hypnotic. In general, alcohol does dull the sense of awareness, slows the reflexes in general. It may also create them to be aggressive or inappropriate behavior, and their coordination is going to be delayed. So as a police officer, I went to DUI school, and they teach you the things to look for in an intoxicated patient, an intoxicated subject. And you don't just assume of their intoxication. You have to, it has to be proven. So So you have to be cautious about that too. Alcohol increases the effects of other drugs and it's commonly taken with substances. So they may take a handful of bars and then drink a couple of beers on it. Again, and then it's just it's a social one that they do, and that's the way that they try to wash their worries away. If patients exhibit signs of CNS depression, provide a respiratory support. So I told y'all from the get-go, the number one thing that we can give to any patient basically we take care of is oxygen. Always give them oxygen. Remember though, if the patient starts to have hallucinogens or they get the shakes, that's probably from the DTs. That is a alcohol withdrawal. So be cautious of those because of the DTs can be fatal. It's something that, I mean, you hear people all the time, I quit, tobacco or alcohol cold turkey. Well, that's amazing. I'm very proud for you. My boss out on the rig, he was an avid smoker for 30 years, had a massive heart attack and didn't touch cigarettes to this day, and he still hasn't touched it. But you have these true hardcore alcoholics they can't quit like that. They want to, but it is something that it's a and when I say it's a drug, it's channels that's something they desire. They want it. They have to have it no matter what they do. And I mean I've seen people get drunk off, they drink Listerine for the alcohol because that's so bad, or Dr. Tishner's because that's a higher alcohol intake, because they want that alcohol so bad. I mean, you can make alcohol in your own home. Heck, they do it in prisons. They make the fermented fruit, and that's what they drink. The mash or whatever it's called. DT. So here's some of the characterized to how they are. So you get your agitation, your fever, your sweats, your tremors, confusion or disorientation, delusions or hallucinations, seizures. These conditions may develop for a person stop drinking when alcohol consumption levels are decreased suddenly. Provide prompt transport, reassure the patient and provide necessary care of emotional support. Now, and I have seen in our state hospital that they do, as to lower the DTs, they do give them a shot of alcohol. Now, it is reduced drastically to where that they're coming off of that, but to reduce some of these symptoms, they will give them a shot of alcohol. It is fixing the problem with the problem, but it has to be monitored and dosed. It's not something that they are like, oh, well, I can drink half this bottle and I'll be fine. Well, no, you're going to be in the same place you are tomorrow, but it's a medical thing that they can give them the medication and a shot of whiskey, and then they can move forward. So I've seen those types of treatments there. And, one thing that they ruled out is shock treatment. They say that doesn't work, but I've been watching a lot of old hospital story things about how the shock treatment and all that. It's kind of crazy. All right, so opioids. We are more common to see in the alcohol, the opioids, and in your prescription drugs more than you don't really hear a lot of the inhalations. Do y'all hear real quick, do y'all hear the dinging going off in the background, or is that just coming through me? Like my computer's dinging and I'm getting a text and I didn't know if y'all could hear that. So
No.
I'll hear. That's a good deal, because I was like, oh God, it keeps going off. I don't, be quiet. I hit the mute button and I can't hear y'all. All right, so we have more interaction with those three versus anything else. So the opioid, so we know it's a narcotic. We know that it produces sleep and more of an altered mental status of a consciousness. They just kind of, opioids are a narcotic medication to relieve pain. They are prescribed. They are supposed to be monitored. I know in the state of Mississippi, every prescription that's written goes into a database that our Mississippi Bureau of Narcotics can track every prescription that Chris Wally was given forever. It's built into this database. They can tell if a doctor shop, they can tell if a certain doctor writes so many narcotics. They track all of that. I know some other states have that. I can speak specifically for us. So I don't really know about other states. Um, you do hear that they the opium and poppy seed. A lot of Afghanistan, the opium and the poppy grows wild over there. They're a very pretty flower. Um, it is something that I say that it's really pretty to look at. But it's addictive. They chew like some other countries chew those like the cocaine leaves. I mean, that okay. I mean, I found does the same thing, but it's in different form. Um, so the name of opium and poppy seed, from which codeine and morphine are derived, but you get those in certain areas. Your coca plants, your different things in different countries it's made its way over here, and it's put us in our country state where we are. I don't know which belief you are. If you some recreational drugs are good, and that's a whole off topic conversation. But um, they have their places. Yes, they are illegal, but so here's some of your common opioids. So Stadol, medications like codeine, which I'm highly allergic to codeine. I can't take that. You get your fentanyl. Everybody knows about the other types of fentanyl that's found on the streets, but you can also get it prescribed to you. Heroin, it's not really prescribed. I mean, some doctors may try to prescribe that, but those aren't like MDs. You get your Vitakin, your Dilaudid, your morphine. Actually, morphine is used on a daily basis, but it is not an FDA approved drug. Did y'all know that? Um, then your Oxycontin. Then those are some of your common drugs that you're used to seeing that are used with their, how do you say it? They are more of your abused drugs that we come across. Prescription opioid drugs are commonly abused drugs in the United States. Some people become physically dependent. We've seen that. We've dealt with that for years and years and years. It's because, like, prime example, the VA. The VA pumps you full of medicines. I know some other buddies that have been given 30 to 40 Dilaudid a month, and they've never taken them. But that's just what the doctor says. Well, this is what our standard protocols are. Is we give you these drugs. He's like, I don't want them. So some of these people just throw medications at you, and they just write the prescriptions, and it's like that's not fixing the problem. What's going on? Let's see. So the central nervous depressants can be severe respiratory issues also. Obviously, if they're not fixed, you're going to have the cardiac arrest. You get your tolerances because they have mass doses and they want to experience the same high. These drugs can often cause nausea and vomiting and may lead to development of hypotensive. So some of your patients that you may go to not only feel bad, but they're so hypotensive that you're like, oh God, like I could have fixed this easily, but I need a paramedic here. I need an advance that can start an IV because you got to challenge that blood pressure and you got to put something in to make that change. Well, you can't really do that in your state right now, but that's some of the issues that you may find. Or they vagal down. Let's say, and I'm going to vagal down. They go to the bathroom and they have a hard stool and they squint to push and they vagal out because their pulse and their blood pressure got so low. That may be your call, but it's also because they're a heavy drug user. And that's probably what's caused that hypotensive, them to be hypotensive and to drop that low. Although seizures are common, they do uncommon, they do occur. Some people will have a quick, small grand mal seizure and they not know it, or when they wake up, they're like, "Whoa, what's everybody doing here? Why are you here?" You don't really see those in a lot of your drug usages. They are there, but it's you get more of your blue, where they get so spaced out that they get cyanotic or they just quit breathing. they have those symptoms to where they're just like, oh, I don't know, I'm chill, bro. And when they wake up, they're all shocked. They're like, they're scared. Same thing is coming out of a seizure. They don't really know what's going on. Narcan reverses the side effects of opiate or opioid overdose. It can be given by IV, intramuscular, intranasally. The fastest way is if they are breathing to give it intranasally. Now, I have also given it on an unresponsive patient, but as soon as I sprayed it, I used my bag valve mask to create that volume of air going through their body, and I kept breathing for them. Now, I mean, I can turn around and start another dose because I only gave 4 milligrams. I can up it to 8, but at the same time, as I don't want to reverse that high so fast that the patient comes around and they get violent and they try to kick my ass. I don't want that. So I try to titrate to effect. So be cautious if your agency allows you to use Narcan. Well, I say in those rapid, quick dosages that most everybody gets, they get the 4 milligrams. So you can't meter doses, if that makes sense. So what I'm trying to say is you can't give a half a dose. You got to give it all. You got to give all of the 4 milligrams. Now, some of your officers that they, in state of Mississippi, there's a big grant through Mississippi Law Enforcement Academy that you're able to get a 8 milligram or 12 milligram initial dose. Now, I'm not a fan of that because you're crashing their high and they're going to be pissed off. So you have to be very cautious about that when you're walking into that situation. Know what your local police has, just so you can be safe about it. I think we just talked about that too. I'm not going to sit there and cover that. Sedatives, hypnotic drugs. So these, they do alter the level of consciousness. These drugs are CNS depressants, and they do alter the level of consciousness with effects similar to those of alcohol. The patients may appear drowsy, peaceful, and intoxicated. So when you get to that point, be cautious, and you don't want to get in somebody's face to where you're like, I'm trying to see if they're intoxicated. I need to smell. Well, I won't take their word for it and treat them as their symptoms arise, not as trying to find a sedative to see, oh, you need to know if it's alcohol or sedative. Doesn't really matter. You're going to treat them the same as a basic. You're going to remove them from the environment. You're going to transport them. And you're giving them a high flow of O2. Unless their status changes to where they go unresponsive and you have to request ALS at that point, that's really all you're going to do. So these drugs that give the option to people as a knockout drink, sometimes those are also considered your date rapes. Be careful about those. It's one of those, these drugs can go into very vast abilities. So be cautious when if they talked about, oh, well, he took that sedative. Well, you need to know what they are and how they got it. Abused inhalants. So here's your regular, your acetones, toluene, xylene, and the hexane. That is like your balloons. What is that noise? Sorry. So some of your gasoline and your halogenated hydrocarbons are abused. They huff gas. I don't know how, because just regular gas gives me a headache anyway. So be cautious about that. Teenagers do it because it's rapidly available for them. You can always tell by your paint thinners and your huffers because look at their face. Most of the time their face is the color of whatever they've been inhaling. So they may tell you that they like gold specifically because their face shows it. Effects of inhalants range from a mild drowsiness to a coma, and those can often cause seizures too because of how it affects the brain. try to keep such patients from struggling with you or exerting themselves, because it's going to increase their heart rate. It's going to create the drug to be more potent. It's going to go through the body a lot faster. Use a stretcher to move the patient, give them oxygen, transport the patient to the hospital. So hydrogen sulfide. So this is where you start to be, somebody tell me what the hydrogen sulfide is. What do you have in your area that has hydrogen sulfide? Anybody know? Oh yeah, you do. I'm with that ugly purple and yellow shirt on. Come on, bro. Come on. I thought I liked you. All right. So, so hydrogen sulfide is also commonly found with natural gas, but here's the problem. So initially, it is a colorless and flammable gas. The sorry, the rotten egg smell. If you smell it, it's too late. It's because you're going to die. So that's, and it's not like it's used to commit suicide. It will cause you to commit suicide when you smell. It's like, oh, I smell ramen, rotten eggs. Well, oh, okay, all right, bro. Sometimes if the patient does it on purpose and they put the hydrogen sulfide like in their car, they will write a note. I've seen this happen before. They write a note and say, please don't open the car. Highly toxic gas in here. But they do that in that way because they want to be found, but they don't want people to get harmed. So I've seen it that way. Majority of your hydrogen sulfide. Once the patient has been decontaminated, management is largely supportive. If possible, if they've had a low dosage of it, you can see them obviously in the full cardiac arrest. Their confusion is going to be a quick onset exposure. They're going to be short of breath. They can lose their consciousness. So small signs and symptoms that will show you not really that is hydrogen sulfide exposure, but there was a toxin exposure, and now you gotta fix what you see. You gotta fix their signs and symptoms. Some symptomatics. It's a CNS stimulant. There is a picture right there. Talks about your MDMA. Those are some of your big ones. Your PCP, your angel dust. It gives you the different names of what you see. I know these are probably old. There's probably some way better street names for everything that we see here, but that's just what they know of. And these drugs right here, you're going to see the hypertension, tachycardia, the dilated pupils. If you notice these, a lot of these will either give you hypo or hyper, and you're going to see the same signs and symptoms. The dilated pupils, okay, well, is that from opioid? Well, the tachycardia can also do the same thing. But your treatment for all these are going to be the same. Sorry, I thought that was treatment maybe next. You want to, supportive care, give them the high flow of O2, keep them calm. MDA is a big abused one. I mean, that's I think it's the UK has a bad issues with MDA being used over there. It's very bad in like their underworld clubs. Cocaine, you can smoke it, snort it, inject it. I don't think you can ingest it, but you can inhalation. Sorry, I don't think you can. Well, I guess you can smoke it, but I know you can ingest it. Like people put it on their fingers, run around their gums. Makes your gums real numb. It gives you're not sleepy when you take it. It does have a sexual effect to it. So cocaine it's people use it for multiple different things. Not that it's that purpose, but that's some of the different things that people use for it. Patients may experience hallucinogens or paranoia. Do not leave the patient unattended. Obviously, they called you for some help, so don't leave them in the back of your ambulance because they may not know what's going on. It's not going to be good. Emerging class of drugs similar to MDA, sold as bath salts, escapes the legal restrictions imposed on illicit drugs. So the worst physical butt beating I ever got was from a guy on bath salts. It's you give everything you got, and you still feel like you got to give more. So the bath salts are pretty rough. I think I want to say they've gotten control over those, but it's a lot better than what it was 10 years ago. Um, so we can, I mean, and a lot of times when you get those calls of, you get them a lot of from them hallucinating, that they see things, they hear things, people are there, they're after get them, and that's how you get the call. So you know initially right off the bat it's not an opioid or anything like that. So your bath salts are very hard. They they do snort them. They will also put those some of your bath salts on their weed. I've seen them smoke it. Uh, I've seen the effects last longer than 48 hours. What it says right there. I know we've dealt with folks in standoffs in my county. You know, 2 to 3 days because we felt that it was good just not to make entry to go get them. But it was, I mean, they get crazy, crazy, crazy. Some of your verse. So here's reason why I've actually seen this. So right here where it says teeth grinding, I have actually seen a patient at our trauma center that was on bath salts, and she was grinding her teeth so hard it sounded just like rubber. You know when you check your tires and you turn your tires and without rolling, you hear that. That's exactly what it sounded like when she was grinding her teeth because she was doing it so hard, her teeth were making that rubbery sound. So that's another reason why we tell you not to put your hands in their mouth. You don't consider, but go ahead and call for ALS. That warrants an ALS call. That does not warrant you to be like, oh, well, I can transport them. Well, they have certain medications that if things turn south that they can sedate them by. So don't just wait around. I promise you, you're gonna want ALS there. Marijuana, that is a THC drug. This chemical in marijuana is it's, it produces a high THC. Now it's not just an what you grow a plant in your backyard. I'm not saying like that, but the way that they're growing them now, the THC is ungodly. They can chemically and lably make these plants grow with such a high THC that they only sell it to, you know, their habitual store users, if that's what you want to call it. It does impair your short-term memory. It does also messes up with your complex of thinking and working. I personally know a lot of people that use it for nerves. It calms their, it makes them just calm down. Their attention deficit, their anxiety, it just slows things down. Um, Euphoria could progress into depression and confusion over time. Um, I've dealt with more other drug overdoses than I have of weed or marijuana. So that's just a personal thing. I just, you know, here it shows you with high doses, a person may become anxious or paranoid. Reassure the patient it's going to be fine. You want to keep your bedside manners really good. Don't buy into their hallucinogens. If they're like, hey, I see watch out, there's spiders on the wall, and you're like, oh, you better get it before it gets you. Don't do that. Uh, it will not be in your benefit, I promise you. I, um, I don't wholeheartedly agree with this last statement. So for me to tell you that marijuana is a gateway drug, I don't believe into that. That's just my personal opinion. I know studies have shown that and other things have done that. So I'm not telling you that they're wrong, but Chris Wiley just does not believe. For your test purposes, just know that it's saying that marijuana is a as a gateway drug. We know that several states have legalized it at the federal level. it still is against the law. That's why it's against the law to transport drugs across state lines, because you're actually traveling on federal highways. It's an international highway. It's federally funded. I'm not saying you're gonna have your federal cops out there, no, but it's a federally funded highway, and the federal government does not know how to tax that. And at the same time, as your dispensaries can't put their money into FDIC banks because that's a federally backed bank, and the banks that receive federal funds are saying that's illegal. So, as you can tell, I've done my homework on that. We also have edibles, baked goods, candies, suckers. You have your vape pens. I think everything, right? I mean, you can have THC cooked in your food. You can have weed butter. I mean, there's so many different things out there that you can use with that has THC in there. You have your synthetic marijuana, or what you're so commonly used to hear, spice. Synthetic marijuana or spice is a variety of herbal instance of smoking blends that resemble the THC, and they do give the resemble of the same high, not the same high, but it resembles that same high. It is powerful, but some of the outcomes is not. It's not the same. Let's put it that way. A spice high can also create a very aggressive or traumatic. You've seen some of these people that they like turn into zombies and they'll bite the faces off people. That is a traumatic, and they've known to be on spice. I've seen reports to where police officers have shot these particular patients multiple times, and they still continue to charge them. It's pretty bad. I mean, that's a spice issue there. So here's some of your hallucinogens. The biggest one that you're going to learn and that you're going to know all the time is your LSD. The very top one, the toad skin, I have heard that there's actually a toad somewhere in the US that you can actually lick, and it gives you a LSD high. I don't know of it. I have never done it, but I know that there is a highly sought after toad that you lick. You've probably also heard of ketamine, your PCPs. It's not the nutmeg on there that you see that you cook with. So don't try to go out there and eat a bunch of nutmeg, because it's not gonna make you hallucinate. Just thought I'd throw that in there too. Some of the agents cause visual hallucinations, intensifies vision and hearing. When they tell you they can actually smell sounds, they probably are true, and they say that they hear purples. It's probably backwards, but it intensifies it all. Anybody that is in a bad trip is going to produce signs of hypertensive, anxiety, tachycardia, and paranoia, because I've always been told, if you have a bad trip, it's probably because of somebody who you're around creates that bad general feeling. I don't know. This is what I hear. But and their paranoia automatically could also trigger into that, and it's feeding off of that. I've known people that take LSD and they said they love it, or they did love it. But that's who knows? I'm not gonna try it, but that's their report. Let's see. You don't want to just trigger these. You want to try to be that passive person to where you don't trigger them to just react to anything and charge at you and potentially hurt you. So your bedside manner needs to be on point for these particular people. Don't try to put that patient in a situation to where it's going to hurt them. Only restrain them if you have to, but you need to have more people to restrain them than what you say. Most of the time, the requirement is one person per limb. But I can promise you, if any of these people are on PCP or anything like that, they're going to be a lot more stronger than what you're ready for. So you want to bring the army when you're ready to restrain these people. because you're gonna have a fight on your hands. Anticoagulant agents, I already know about these. Hot as a hair, bond as a bat, dry as a bone, red as a beet. That's all I can go off of, y'all. Let's see. It says common drugs include atropine, Benadryl, Jimson weed, and Elvil. I don't know what those are. It's often difficult to distinguish between an anticoagulant overdose and a symptomatic overdose because groups of patients may have been agitated and have tachycardia and dilated pupils. Just treat them as for the tachycardia and dilated pupils and the respiratory. Obviously, you're going to need ALS assistance. And you want to transport them because I know these particular patients can crash on you. That's about all I know on them. I besides what they say right there. I know that what it shows right there says the patient can go from normal to seize and death within 30 minutes because their internal core heats up so fast that you can't have a rapid way to cool them. That's all my notes tell me about y'all. Say overstimulate normal body functions are controlled by the parasympathetic nerves. These are nerve gases. These are also found in warfare. I think due to the Geneva Convention that gases are against the rules of war. So these haven't been used for hundreds of years. I'm not going to say that some countries don't use them, but it's supposed to be banned on war that everybody's agreed upon. Anytime you have a exposure that you think it's a gas or a nerve agent, you're going to use the dumbbell acronym. You're looking for diarrhea, urination, meiosis, bradycardia, bronchospasm, bronchouria, emesis, lacrimation, seizures, salivation, and sweating. Those will help you identify that it is a potential nerve agent. There's also another acronym that we're going to show you in a second. There you go for the sludgem. It's the same exact thing if you notice from the dumbbells to the sludgem. They ask the same questions, just in a different form. I'm used to the sludge acronym. That's the ones that I know that I can go off of. The muscle twitching and meiosis has been added in the last couple of years because that's just something new that they've noticed over time when they have an accidental exposure and they treat these patients and they learn from their mistakes and they try to make things better. So that's where the EM comes from the emesis and the muscle twitching. The most important things about these is to avoid exposing yourself because if you get exposed, who's going to treat you? Nobody. So you need to be very cautious about that. Right there where it's talking about decontamination may take priority over the immediate transport. That is correct because on the exposure is going to stick to them to where if their armpits, their groins, their around their neck, their nose, their mouth is going to create moisture. It's going to stick there, and the more exposure that you have, it's just like COVID. Now you're a secondary exposure, and you're automatically going to be treated the same, and it's going to affect you too. So now you've potentially harmed yourself instead of allowing for them to be deconned. Unfortunately, if they don't survive that, but you still have done the right thing by delaying transport because they have to be decontaminated because of this particular nerve gas. So those are some of the things you have to be very cautious about. Now that may be more into your terrorist / industrial environment or chemicals, like a chemical plant environment, that you may run across those. It's not something that I'm going to say you're going to see at your everyday EMS run, but again, be cautious of that. Some of your nuclear sites have this. There's actually a very big training facility in Georgia that has every chemical, biological warfare weapon gas that you can actually. Well, you have to be cleared to go to the school, but you can go there and learn how to use it. It's a really cool class. The first time I've ever had to put anthrax in my hand. That was really cool. But you're tracked on a record for the rest of your life. Just letting you know that. Some of these places may have the duodode auto injectors. The best thing I can tell you about this, if nobody's ever done them, if you know that you have to give yourself these injectors, we were trained and we train people. If you have to give this, because you give it to yourself in the heart, get on your knees because it's less distance that you have to fall when you pass out. Because it's like a kick in the chest by a mule. It's it's a lot. I can promise you that. It hurts. But like this, the trainers hit the same hard. They're very, very powerful. It looks like an EpiPen, but it's a dual needle and has like a 20-pound spring on there because it needs to go through layers of clothes and your chest muscles and walls and all that. So just saying, I don't know everything, but I know about these. So here's some of your miscellaneous drugs. We talked about this. Beta blockers are also very bad in children. It can create cardiac dysrhythmias. It can kill them. You can see your like your aspirin, your oil of wintergreen can be very fatal too. And that's something that you take over the counter. That is just right there. Stimulants and street drugs. I guarantee you, everybody right here, there is 11 of us total. Unfortunately, we probably could make less than 5 phone calls. And out of all 11 of us, we probably could have any one of these drugs that we wanted. If we had to or wanted to or needed to, we could find it. And that's bad because we just we know people, but that just shows you how how bad that it's out there. What we say no, there's not a problem is because either one is we don't want to recognize that there's a problem, or we just try to turn the blind eye towards it. So unfortunately, be cautious of your other miscellaneous drugs. That's why we like to tell you if it's an old drug and it's out of date, expired, or dusty, or get rid of it. You can take it to your local police station. Some police stations have drop boxes. Your local pharmacy may dispose of it too. But don't leave any drugs or anything around that your children can get a hold of. Well, there you go again, contact poison control, because they are a vast resource of information that will help you identify, treat, and they can give you where the closest location to take that patient to. If let's say you're working for another county or company, same company, but they send you to another county and you just don't know the area. It's a resource if you happen to get that miscellaneous overdose and you're not really sure what happened. They can help build you a case, and also contact the medical facility also to pass on some other information. Ingesting too many aspirin will result in nausea, vomiting, hyperventilation. There's a lot of things that you can see that we normally deal with. The ringing of the ears, it's serious. If you've never had that, it's annoying. So the hyperventilation is because the body's trying to burn it out and do away with it, but you can see those signs even I'll say early and let's say mid to late of the overdose. So of the poisoning from aspirin. Patients will have problems with anxiety, confusions, tachypnea, hyperthermia, and danger of having seizures. You want to try to keep them warm, but at the same time as they're going to try to remove their clothes, like, oh, it's hot, I can't breathe. They're confused. You're gonna continuously say the same thing over and over and over, and you're just like, oh my God, just pay attention to what I say. So be cautious of that. Any of this are dangerous. Obviously the seizures. hypothermia. Depends on what part of the country you're from. It may be worse than others, but I know Mississippi, we only get snow like every 5 years. So we don't really have to worry about hypothermia. Now, it will get cold. Deer season specifically, it gets really cold, but other than that, hypothermia is body's just shunting, and that's why they go through hypothermia. Overdosing with acetaminophen is also very common. Some alcohol, actually, no, acetaminophen overdose is a serious, and can be intentional, can be unintentional. Some alcohols include methyl alcohol and ethyl glycol, are even more toxic than ethyl alcohol, which is drinking alcohol. Both will cause severe tachypnea, blindness, renal failure, and eventual death. That's alcohol poisoning. When we start talking about these, we can drink those, and that can be an alcohol poisoning, which will cause death and just shuts down of all the internal organs, and they die themselves, unfortunately. We've all had food poisoning. Just remember that is a toxin also. And if you take these food poisonings, just know that doing a good report, because it could come down to a very large case to where, let's say, like a meat has been exposed to something, and you run a couple of calls on it, and let's say later down the road, CDC contacts your agency because you've transported these patients, and they may want some of your information. So just remember that's also it's a small category of your toxins, but it is considered part of that also. There's some of your common causes of food poisoning. Listeria is the one that you hear a lot. Salmonella, Staphylococcus toxin. I can't pronounce some of those, so we're going to let that go. The norovirus. What is that? The rotavirus. I'm sure there's a coronavirus in there too. I'm sure it's exposed. It'll be on food before you know it. Salmonella is characterized by severe GI. I don't really want to go over this because I think at food poisoning, we're all grown adults. We have dealt this. We've learned this. It's been preached down our throat. We know what to look for, how to expect that, because it's more common than what we think. It's, as you see right there, the bacterium Staphylococcus is quick to grow and produce toxins in the food. So be careful. That's the reason why when you cook a food, you want to make sure you put it up in the refrigerator. You don't want to leave it on the counter for a long period of time because it can create the bacteria also. Bread, we know that has the penicillin that grows onto it. It's that bacteria. There's some of your symptoms: blurred vision, weakness, difficulty speaking. You can't leave the bathroom because you're either going to poop it or vomit it. So you don't know what to do besides you want this out of your body. It's time to go. It needs to rid me. Just because it's a GI issue, or listening to their signs and symptoms and history and your assessment questions, you may be able to realize it is a possible food poisoning or a GI infection or a GI upset. Now, trying to figure out if it's upper or lower, that's a little bit more depth, but you can ask the certain questions and be like, well, it may not have progressed all the way down into the small intestine, so you may have not got down to a lower GI complaint. It may still all be upper GI, and those are just as gross. Plant poisonings here, we were talking about this early. I know, there it is. Mistletoe is highly toxic if it's ingested, so be careful. But there's the castor bean. Does anybody know what castor bean, what it also makes? I kind of want y'all to Google that because that is one that's really neat for y'all to learn. Just to see if y'all know what toxin comes from that. Anyone?
That's a hard one. Even I don't know that one.
That ain't no hard one.
They're used to make paints, varnishes, and lubricating oils.
Yeah. So, has many
Lead
uses.
poison.
Lead poisoning. You can get that now. They have changed it a few I mean, you showing some age right there. That's on you to show that you know what lead poisoning is. I'm just saying. I didn't call you out. But so a lot of these things that you hear have their past that shows now you understand why they've been put on this list. I'm not real sure what pokeweed is, but I can tell you, I don't know what goober ate a bunch of mistletoe just because you're trying to kiss underneath it. I don't know what you're trying to do by getting it in your body, but we now know that that's also a toxic plant too. Y'all can read that very topic. It is very impossible to memorize every plant or poison, let alone their side effects. That's what we've got Google in your hands for. I Google a lot when I take care of patients. I'm like, oh, you know what medication? That's 13 syllables plus some. Let me write that down. Let me Google that. Oh, that's because you got low sugar. It's some of those. I mean, they come out with new drugs every single day. Unless you're a very active pharmacist, sometimes the pharmacists don't know them all either, but they won't tell you that because it says MD behind their name. So, but I'm gonna tell you, if you take that plant to the emergency department, you don't just cut a little bit of it off. Hey doc, we brought you a plant too. Be careful, don't eat it. That's what this patient did, and that's why we're here. Here's some pictures of some of the plants. There's B is mistletoe, C is the castor bean, D is the nightshade. I hear the foxglove is wild, and the rhododendron. I think those are actually they're all wild, but they are. I mean, they're pretty. I mean, not gonna say that nothing's wrong with them. I'd like to see that the nightshade, just personally, just me. Here is some other ones. Your Jimson weed, your death cams, poison ivy. I know why that's deadly because I try to pull my skin off. Your poke weed, your rosary pea, and your poison sumac. Those are all some of that fall in there too. So when we do that, just know that those are all part again, trying to figure out what they all are, how they do. That's one of those things that we just don't know. We don't, but I'm gonna tell y'all, the rosary pea, that looks kind of scary. I thought it was a bug at first. There's tons out there. If you're out in the wild a lot, it is helpful to know what plants you have in your area, so you can be cautious of that. But again, just use caution. So that's the end of the class tonight. Does anybody have any questions, concerns, problems? Anybody want to talk about anything? Did I go over anything? Y'all have any questions? I mean, I would say thumbs up to you too, but you still got that ugly shirt on, bro. I was gonna say hotty toddy, bro. That's all right. We look better than y'all.
This is all the way, man.
I can't help but give y'all a hard time. All right, folks, listen. Y'all want this right here? That is your class code for the night. I randomly come up with these just so y'all know. It's not like it's a big deal. So there's your class code tonight. Please make sure y'all write that down. It is 8?5 money symbol 90. If y'all have any questions, concerns, or problems, please hit me up on Discord. I'll be glad to help y'all out. I'm going to get off pretty quick because I am starving after today. So y'all have a good night. Well, I'll see y'all Thursday, and we will enjoy it again. Y'all be safe, and talk to y'all Thursday.